I'm Josh, I'm one of the R1s, and so this will be my grand rounds topic, optimizing identification of bladder tumors. So I'll talk a little bit about an overview of some of the examples of technology where cystoscopy is enhanced, and we'll talk about some other future directions and other technologies that are a bit more novel and might not be as easily recognized. So someone presents to your office and they have hematuria as their presenting complaint. The first thing that we're always kind of anchoring on is, could it be malignancy? And the way that we would assess that in the office is cystoscopy to rule out a bladder tumor or a bladder mass that would require resection. But when you diagnose bladder cancer, you actually need to first recognize that there is something suspicious in the bladder to resect it. And in most cases, that requires you to actually identify something suspicious on cystoscopy when they first come in. When you do eventually bring them to the OR, an adequate TURBT requires that you resect all the visible tumor, but that you also adequately resect to muscle so that you're able to assess your muscle invasion. But this is quite challenging sometimes because patients can have carcinoma in situ, which can be extremely difficult to visualize on white light. Sometimes they have very subtle mucosal changes, if any at all. And ironically, having CIS in particular is associated with a poor prognosis and automatically makes you high risk. Overall, trying to estimate the depth of invasion, the grade of a tumor just by looking at it on cystoscopy is very inaccurate. And this all leads to your rates of recurrence and progression after your initial resection being very high. Studies have shown that you can find residual tumor in restaging TURBTs in up to half of patients and upstaging in up to 15%. And so it all suggests that there are significant gaps to be filled in terms of trying to optimize identifying tumors, helping you resect them completely. In other words, is there a way that you could enhance cystoscopy? Could we improve the identification of tumors? Could we try to improve the adequacy of resection? Is there a way of maybe changing the way that cystoscopy is used as follow-up? Well, you could imagine if we could find a way to improve the contrast or the outline of tissue, that would make it easier to resect. Perhaps there are technologies that are coming out that would help you identify the depth of invasion, which we'll talk about. And as a very growing topic, how can AI be integrated as well into this whole context? So that brings me to the first technology, which most likely most of the urologists here have used to some degree or seen, blue light cysto. So in summary, what blue light cysto is based off the administration of a compound to induce your accumulation of protoporphyrin 9, which is in the heme synthesis pathway. And protoporphyrin 9 in particular is fluorescent when blue light is used to shine onto it. And malignant cells in particular accumulate protoporphyrin 9 in greater amounts compared to benign tissue for various reasons, but it's thought to be in combination due to increased metabolic activity, reduced activity of the FECH enzyme, which converts it into heme, as well as differences in the rate of membrane transport. And so by administering a naturally produced compound called 5-ALA, which is in that pathway, these cells will preferentially accumulate protoporphyrin 9 and therefore fluoresce in comparison to the background. But 5-ALA is not actually the compound that we use these days. You may have heard of something called cisvu, which is also known as hexaminolevulinate, or HAL. And what this is an ester derivative, which is more lipophilic than 5-ALA. And so it's taken up into cells more rapidly and metabolized into 5-ALA, which induces the same effect with fluorescence by accumulation of protoporphyrin 9. These are some examples of images taken on blue light cystoscopy. So as you can see in the top left, you could argue that the mucosa there does have perhaps some degree of change and looks a bit suspicious, but you could very easily sweep over that and not notice it. Whereas on blue light, it just pops out at you. And likewise in several of the other images. In the top right, those are some examples of papillary tumors. You could argue that you're able to fairly easily identify them on white light cysto, But some of the smaller ones, you could feasibly miss them if you were just doing a quick scan of the area. But on blue light, they are very, very obvious and in contrast to the background. So, what are some of the studies that have taken a look at the use of blue light? Well, this first pilot study by Kriegmeier in 1996 used 5-ALA and instilled it in a subset of 104 patients. So all these patients got white light cysto first, then they underwent blue light, and then they took biopsies of all the areas that were suspicious under white light and blue light and compared it with a 2x2 table to determine the sensitivity, which they found was significantly higher than that of white light cystoscopy. Later on, Berger showed in a retrospective study comparing white light to 5-ALA and HAL that it appears that your residual tumor, when you did a follow-up TURBT, seems to be lower when you use blue light cysto, and that your 3-year recurrence-free survival also seemed to be improved when using blue light cysto. But perhaps the most notable difference here is that there wasn't really a significant difference that was noted between 5-ALA or the use of HAL. So why bother using HAL or Cysview these days? Well, what we know is that because it's more lipophilic, it's taken up rapidly into cells. And so it's been shown that you can induce a similar degree of fluorescence by using HAL, but at a lower concentration and instilled for a much shorter period of time. So it makes it the more practical choice compared to 5-ALA. And as far as I'm aware, I think it's the only approved compound now in Canada. Now, in terms of how this is actually panned out in the real world, Danishmand in 2018 published this study, which was a prospective real-world blue light cysto registry, including over 1,600 samples across 641 white light and blue light procedures. So all these patients got white light first, then got blue light, and in determination of where and during what types of light lesions were suspected to be malignant, they took samples and biopsies of it and determined that the sensitivity of white light, blue light, and the combination of both of them recognizing something was likely malignant was 76, 91, and 98.5% respectively. And they determined that adding blue light cysto to white light cystoscopy seemed to improve both your detection of papillary lesions, but also even more so CIS, which was that group of patients that often have more difficult to identify mucosal changes. But perhaps the most notable thing here is that they estimated that 6% of patients actually had a migration in their AUA risk group by using blue light cysto. And ultimately, 14% of patients had a change in the recommended management, which they defined as either receiving intravesical therapy when it was not previously planned, changing the duration of therapy, or proceeding with cystectomy. Now, this was a meta-analysis done only on RCTs using HAL specifically. And Berger demonstrated that a quarter of patients who had blue light cysto were able to find at least one additional non-muscle invasive tumor that was missed on white light cysto. And over a quarter of patients had CIS that was purely detected on blue light cystoscopy. But perhaps the notable thing with the outcome is that the recurrence rate at 12 months was significantly lower with blue light cystoscopy. And this was based on a subset of 9 prospective studies that were included in the meta-analysis. These are just the forest plots showing the favor in detection of non-muscle invasive disease for blue light cysto, CIS, and your 12-month recurrence rate. But the outcome here that we still haven't really discussed is progression. So where do we stand in terms of progression? Well, this was a meta-analysis by Yuan in 2013 on 9 studies, but it seems as though they didn't find a significant difference in the rate of progression into muscle invasive disease. However, if you actually look a bit closer in the forest plot, you could make the argument that amongst the studies that were studying HAL, there seems to be a trend towards favoring fluorescent cystoscopy, but it just wasn't statistically significant. And when you actually look into studies more, you realize that the follow-up was only ranging from 9 to 24 months. And what we know is that high-grade recurrences can take multiple years to evolve into muscle-invasive disease. So you could posit that these studies lack the follow-up that's needed to actually reasonably measure progression. So what has been done to try to address this? Well, more recently, this Cochrane review was done in 2021, including more studies, more patients. And here they were able to demonstrate again that there is a reduced recurrence when using blue light cysto, but they also suggest that there's a reduced rate of progression when you use blue light cystoscopy. But the overall body of evidence was of low certainty because the studies that were included were of varying quality, low sample sizes, had a mixture of 5-ALA versus use of HAL. There were significant differences in the use of post-op chemo or induction therapy. Now, we've already seen pretty reliably that blue light cysto seems to decrease disease recurrence. But why are we able to see an improvement in progression this time? Well, this study is obviously more recent and was able to include more studies in the meta-analysis, but notably, Dragoescu and Rolovich, that were both done in 2017, had follow-up up to 60 months. And as we had just discussed, allowing further follow-up could potentially improve your determination of progression, giving it time to actually progress and give you that effect. And furthermore, with a larger sample size, you have more power to find this difference. So even though the overall body of evidence is of low certainty, it was nevertheless a significant result here. But there are, of course, still critics. As we had discussed, the body of evidence is low certainty because there's so many differences in the studies. One could argue that the pathways that were taken in terms of their treatment decisions were outdated. So here in 2022, attempted to correct all of this by doing a more recent study. And on paper, it sounds like a pretty robust study. Well, it's a multi-center randomized controlled trial. It includes over 500 patients, all of which had suspected intermediate or high-risk non-muscle invasive disease. Patients were randomized to either get white light cysto or blue light cysto. All eligible patients got a single dose of mitomycin C, and the median follow-up was pretty reasonable. But the result was controversial. It didn't find a significant difference in both recurrence or progression, and there attached is the Kaplan-Meier for recurrence. So why might that be? You know, we've had so many previous positive studies, meta-analyses, Cochrane reviews that have all demonstrated at least a pretty reliably reproducible effect on recurrence. But now this single study here completely contradicts all of that. Well, what we know is that the study is likely hugely enriched for intermediate risk patients because before you get TURBT, you can't really tell if a patient is high risk without having a positive cytology. And we know that only about 23% of these intermediate risk patients were even exposed to BCG. And those who were mostly didn't get adequate induction or maintenance. By current guidelines, many of these people do not get single-dose chemotherapy regardless. And the overall representation of CIS was underrepresented. Interestingly, in this study, blue light cysto did not detect more CIS overall, to suggest perhaps there was a selection bias here as well. And so all of this led to a decreased external validity of these findings. Perhaps this could be applicable to intermediate risk, given that was the main population, but that's not everyone. And the other thing to note here is that when you look at the curve, it seems the curves do converge closer towards 5-6 years. But at the very beginning, at 12 months, they do actually seem to have a degree of separation in favor of blue light cysto for recurrence. And perhaps this suggests that within the first 12 months, it's a reflection of your quality of resection, which could be augmented or aided by blue light cystoscopy, whereas by 3, 4, 5 years, it ends up being an example of just your natural history of intermediate or high-risk disease. So where do we stand in terms of the outcomes? I think we can clearly identify that you can better identify bladder tumors, that you can reasonably get an effect on your reduction of recurrence rate, but there are people who argue that the impact on progression is still less clear. But even if that's the case, to have a reduced recurrence rate implies that your overall treatment burden for patients, their quality of life, and the economic implications all have significant benefits alone. And even though there are significant upfront costs to set up and deliver blue light cysto, one could imagine that if you can reduce recurrences, if you could even reduce progressions into things like surgery, cystectomy in the longer term, it could ultimately be extremely cost saving. So where do the guidelines stand? Well, AUA, EAU, and CUA all provide kind of moderate to weak recommendations, and they all state when available, you can use blue light cysto to increase detection and decrease recurrence. And we've kind of highlighted some of the evidence behind these guidelines. But you may notice there's something else, a bit foreshadowing of the next topic. EUA also recommends something called narrowband imaging. So what's that? Well, narrowband imaging is another enhanced cystoscopy technique whereby two specific wavelengths of light are shown onto your bladder mucosa. And the thought is that they're specifically absorbed by hemoglobin, which helps bring out contrast in vascularity or hypervascularized tissue, such as malignancy. Its use was first described in a colorectal context by Sano. And here is just a nice overview video explaining the technology as well. And here are some example images. So just to review, the superficial vessels tend to appear more red, and then deeper vessels appear more cyan or blue. And so you can see here in the top left, those little red spots likely representing superficial vessels. Below that, those larger vessels that are deeper down appear to be more cyan or blue. And then you can also see the top middle there, papillary tumors seem to pop out a little bit more against the background contrast, appearing more red, presumably due to superficial vascularity in them. And then another example on the left there. But does it actually help? Well, we can say pretty reliably that it can improve your detection of tumors. There's a meta-analysis including 1,000 patients over 7 studies, and it showed that narrowband imaging could help you diagnose disease in 17% more patients and identify an additional 24% of tumors, both on a patient level and on a tumor level analysis. But what about the outcomes? Well, this was an RCT by Naito in 2016 on almost 1,000 patients who underwent either white light cysto or narrowband imaging assisted TURBT. And what they showed was that there were similar rates of recurrence in 12 months. In other words, it was a negative study, not statistically significant. But the interesting thing is, specifically in the low risk group of patients, they actually did find a significant difference in your rate of recurrence at 12 months. These are the Kaplan-Meier curves. A represents all patients, B is your low risk, C is your intermediate risk, and D is your high risk. And you can see with the low risk, there is a divergence in the curves. So why might there be improved outcomes specifically for low risk in this population? Well, you could imagine that in low risk patients, by definition, that means you have to have a small, low grade papillary tumor. It has to be individual to identify it and be able to actually properly assess that you've done a complete resection, that you've removed all the suspicious looking tissue. Perhaps that process is actually improved or augmented by use of neuroband imaging. And so the quality of that resection of that singular lesion makes all the difference in terms of reducing a rate of recurrence. Whereas it's a lot harder to do a complete and adequate resection when you have multifocal, intermediate, or high risk disease. This has been studied further with a Cochrane review as well in 2022, comparing 2,000 patients over 8 RCTs. And here, again, they do demonstrate that it seems use of NBI reduces your recurrence over time compared to white light cystoscopy. But the overall body of evidence was low, again, due to heterogeneity in the design of trials, low sample sizes, and some contradictory findings between trials. They did not do an analysis on progression here. And that's something that is still somewhat lacking in terms of study. This is just a forest plot demonstrating the Cochrane review, but you can see here that even of most of the studies there's definitely a trend towards favoring use of narrowband imaging with white light cystoscopy TURBT, representing a recurrence benefit. But beyond the outcomes, narrowband imaging also has some very specific advantages. So notably, you don't need to instill an agent, unlike blue light cysto. So there's no additional cost of a reagent. There's no time that you have to wait for the reagent to actually take effect. You just turn it on and go. And because of that, you can use it anywhere. It has been explored as a possibility for augmenting your ability to do ureteroscopy when you're looking for upper tract lesions. But this has been studied to a degree. Soria and colleagues in 2021 did a registry study, something called the CROWS registry, which had over 2,000 patients. And they didn't find a difference in outcomes by using narrowband imaging enhanced ureteroscopy. So where do the guidelines stand for narrowband imaging? Well, kind of similar to that of blue light cysto, but the AUA, EAU, and CUA all state that when it's available, you can consider use of NBI to, again, increase detection and decrease recurrence. But overall, the recommendation is of lower quality. AUA has downgraded it to just a conditional recommendation, and the strength of evidence was grade C, likely owing to less study, less literature in the field, lower sample sizes, and further heterogeneity in the studies. But certainly, it's an area that's worth further consideration and further study in terms of how it can be integrated into your potential daily workflow. But shifting gears a little bit, blue light cysto and NBI, these are things that are actually integrated into your guidelines, but there are technologies that are still evolving day to day. And one example of this is optical coherence tomography. You may have heard of this technology before in the context of ophthalmology because they use this to actually scan your retina. So what is OCT? OCT is a technology which is somewhat similar in principle to ultrasound, but instead of using sound, which is redirected to tissue, you use light in the near infrared, which then bounces off tissue and can be scanned to determine the depth and tissue structure. And because light travels much faster than the sound, you're able to get a far greater resolution and a penetration depth of just 2 millimeters, which in some sense is similar to that of taking a little biopsy as a point of care measure. And they've developed a probe with OCT that can be fit into the working channel of a cystoscope. Now, in terms of the use of it, you need to consider that because it's this very small probe, you can't really use it to scan your entire bladder mucosa at once. You have to carefully select areas of the mucosa that you want to check for. Otherwise, you'd be there all day trying to scan every square inch of your bladder. But why does this matter? Why do we care? Well, Pan demonstrated the use of technology in a rat bladder model and showed that you could actually detect abnormal growth of urothelium even when the surface appeared normal on cystoscopy. And it leads to questions. Could you tell reliably what was benign from malignant? Could you even predict grade at bedside? Could you estimate the depth of invasion or the stage in real time without needing to wait 2 to 3 weeks for a pathologist to tell you? Well, this company called SkinVivo, which is one of several providers and companies that are trying to develop a probe for use, believe so.
Curious for the next generation cancer discovery tech that will drastically improve bladder cancer treatment and care? Staging is key for effective bladder cancer treatment. Traditionally, to accurately determine the extent of bladder wall invasion, resection and pathological examination of the suspicious lesion were mandatory to craft a personalised treatment plan. Introducing the SkinVivo OCT imaging platform, a groundbreaking solution that transforms cancer diagnostics. The OCT imaging catheter utilises advanced optical coherence tomology to reveal the structural tissue morphology of the bladder wall in real time during cystoscopy. This supports you on the fly to confirm malign or benign, including the stage of the tumour. Our catheter is small enough to fit within the working channel of a standard cystoscope and uses a patented MEMS mirror to capture a cross-section of the tissue at 60 frames per second. With the central software on the base, you can capture both snapshot images and videos that can be saved with individual annotations alongside the location information. Using the SkinVivo solution, urologists will be able to see into the depth of the bladder wall in real time instead of just looking at the surface. This means that, amongst others, re-TURBTs can be reduced, bladders can be spared, and unnecessary surgeries in the follow-up can be prevented. The OCT base and disposable catheters are used as compatible add-ons to standard hospital equipment and barely add 10 minutes to the existing procedure. We're currently advancing to stage 2B clinical trials and invite you to join us in this journey to improve bladder cancer diagnostics and care. For more information or to get in touch, simply...
They certainly do a good job at introducing it. I feel like I'm ready to invest. Anyways, these are some example images of OCT. On the left, in A, that's a representation of your normal bladder wall. And so what you can see in that top layer is a layer of kind of lower contrast, but it's quite thin, and that represents your normal urothelium. Under it is a higher contrast area with some blood vessels. That's your lamina propria. And then underneath that is an area of lower contrast again, but with those horizontal lines, which represents your muscularis. And B is a demonstration of a tumor invading into your lamina propria, in which that kind of interface between urothelium and lamina propria is a lot less discernible, but you can still see the darker area of muscularis pretty reliably underneath that. Towards the right, some more examples. A is an example of normal bladder wall. B has been annotated as an example of carcinoma in situ, which they note is a representation whereby the urothelium is of lower contrast than would otherwise be normal. C is an example where there is TA carcinoma because that urothelial layer is thicker than normal, but you still see easily discernible lamina propria and muscularis underneath it. D is, again, an example of T1 invasion, whereby the interface between your urothelium and your lamina propria is disrupted, but you can still see those horizontal fibers underneath representing muscularis. And then finally, E is an example of muscle invasion, where there's a complete loss of all discernible layers, including that of your horizontal muscle fibers. But does it actually work? Is it reliable? Well, this study by Sung, which was a multi-center prospective trial in which they took 72 lesions, which they were pretty confident were malignant, were studied with cystoscopy, white light cystoscopy in real time by the surgeon, and they were asked, based off your visual findings on cysto alone, do you believe this is T1 or greater? And they compared it to the findings on OCT. And what they showed was that using OCT improved the overall sensitivity and specificity for predicting tumor invasion into lamina propria or beyond. And the overall accuracy of predicting invasion was improved compared to using that of white light cysto. But it wasn't statistically significant. You could say that likely the study was underpowered, but certainly it's a technique which is worth further evaluation. But let's kind of put prediction of invasion aside. Could it tell you reliably whether something was malignant or benign? Well, this was a meta-analysis including almost 2,000 lesions across 11 studies that were all evaluated with OCT. And with OCT, they determined whether they thought it was malignant or benign and compared it to pathology results and found that you had very reasonable sensitivity and specificity of this novel technology. But there are several other contexts in which OCT could be theoretically used. Say you have someone who has BCG and they come back in for their surveillance cysto and you see a suspicious red patch. The question you have is it recurrent CIS or is it an inflammatory patch? Well, this group, Chang and colleagues in 2023, believes that using OCT can help you actually identify that at the time of cystoscopy. So they did an ex vivo study where they took tissues that were pathology confirmed. 7 were CIS, 18 were examples of inflammation, and 14 were totally normal across 27 patients. And then they analyzed those tissues with this program called MultiPipe, in which it converted OCT images of those specimens using polarized light and converted them into these quantitative numbers that were representative of a couple of metrics. The first thing was birefringence, which is the property of a material having a different refractive index depending on the polarization of light. And the second thing was light attenuation, which represents a reduction in your intensity of light as it passes through material. And what they found is that by plugging in the OCT images of these various specimens and getting that quantitative metric, you could find a significant difference in both metrics comparing CIS to inflammation and CIS to normal tissue. Raises the question, is there a future in which you could take an OCT image of a suspicious patch in the office, have it immediately plugged into a computer, and for the computer to tell you this is most likely malignant or benign? How else could you feasibly use OCT? Could you potentially rule out persistent disease after you have neoadjuvant therapy? Someone comes in, they get a surveillance cystoscopy, they can actually scan the areas that were previously suspicious for muscle invasion and show that that seems to have resolved. Could it help preserve more bladders? Could you potentially reliably say that a repeat TURBT is not needed when you resect a T1 tumor? Perhaps OCT could help you determine that you've done an adequate resection, that there is nothing invading into muscle, that your muscularis layer propria is not disrupted. Those are all potential areas that OCT could be used. And I haven't found too much in the way of study or research in these areas, but I'm sure over the next few years, it's going to be an area which is going to be explored much further. But speaking of kind of evolving fields, artificial intelligence is something that's starting to envelop us in every way possible. Yeah, the advent and rise of ChatGPT, of various different AI programs that are all integrated into our social media. It's a very quickly evolving world, and it's a new frontier. The context in which AI can be explored as an adjunct to cystoscopy are seemingly endless, but these are just some examples. Could it help you stitch together cystoscopy images to form a bladder map to help you in your follow-up of patients? Could it tell you in real time and annotate your images? This is tumor or this is not tumor. Is there a future in which people who are not urologists, non-experts, are able to help perform cystoscopy because you would be able to simply review it at a later time? Or perhaps the AI would be able to annotate or review it, and you would be able to make an informed decision based off of those results. Well, we already know that people are developing these kinds of neural network programs, including CystoNet. This is a bladder tumor detection software that they trained over 95 patients and validated on 54, demonstrating very good per frame sensitivity and specificity and per tumor sensitivity. These are some examples of the technology. And so what they do is they hook up a computer to your cystoscopy module, and then it will, in real time, segment your images, pointing out the areas that it believes are malignant, papillary tumor, but also flat lesions as well on the bladder mucosa. This right here is a video from that same group demonstrating the technology in real time.
It can identify papillary lesions, as well as flat lesions, as demonstrated on the white light cystoscopy images. A surprising finding was that when blue light cystoscopy was turned on, CystoNet was still able to detect lesions, even though it was not specifically trained to do so.
So this video demonstrates a couple of interesting things. So first off, notice how it can actually annotate multiple different parts of your image at the same time. So even if you have 2, 3, 4 tumors, it would individually segment all of those and demonstrate them all in real time to you. But the other thing is that it works seemingly for blue light cysto, even though it was never trained on blue light cystoscopy images. And that does raise an interesting thought. If we were to train it for blue light cystoscopy or use of narrowband imaging, could you potentially further improve its sensitivity and specificity for determining lesions? Could you augment the power of AI or use AI to augment the usability or the accuracy of other enhanced cystoscopy technologies? It's an area which is still very infant in its exploration, but this video is a bit of a teaser to what might be coming in the next few years. But why does it matter? Because you could argue that all of those lesions are fairly obvious to your expert urologist. Does it actually do any better? Well, this group seems to think so. They performed, or they developed a similar program that they named the Cystoscopy Artificial Intelligence Diagnostic System, or CAIDS, that was trained on a set of 70,000 images across over 10,000 patients. Every single image was confirmed with pathology to be either positive or negative for malignancy. And by doing that, they were able to create this program that will assign heat maps to every single pixel within your image, frame by frame. And on the basis of that, determine what areas it thinks are most suspicious for malignancy, whether it's papillary or flat. And they actually use it to compare to urologists, either expert urologists, new grads, or trainees. And what they did was they provided each of these groups with a subset of what they defined as 260 complex images, which were not obvious tumors. So there were examples of things like inflammation, carcinoma in situ, small tumors, scars, lots of things that could potentially be borderline cases and are historically more challenging to determine for even the expert urologist. And what they showed is that using this CAIDS system, they were able to develop greater accuracy, sensitivity, and comparable specificity to that of the expert urologist. The other thing is that it analyzed the images extremely quickly. So it analyzed all 260 images in just 260 seconds, 1 second per image, whereas it took the expert urologist 35 minutes to get through the entire set. But perhaps the most interesting finding here is that it could potentially augment and improve these overall accuracy, sensitivity, and specificity of the expert. Because when they use the CADE system as a diagnostic tool that the expert could use to make an informed decision about whether something was malignant versus benign, it improved their overall metrics here, as was demonstrated in this table. And in fact, the best specificity for any group here was using that of the expert with the CADE system together in combination. But it goes beyond that. Is there an all-encompassing solution that kind of incorporates all of these different technologies? Well, Suarez and Ibarola developed something of an endoimaging system where there's sensors attached to the cystoscope that can track the rotational and translational movements, and an algorithm then subsequently develops a 3D bladder map. But not only that, it also segments images. So it can determine in real time where you are in the bladder, what you are looking at, whether it is tumor or stone or scar, and then form this 3D map annotated with the locations of those different lesions or findings for later review. These are uploaded to the cloud, and you can actually review them in the comfort of your home, on your office computer, anywhere for further follow-up. This kind of raises the question that we had alluded to a bit earlier, but could you potentially use this as a way to improve overall follow-up when you're comparing cystoscopies? Say you have someone who comes in for a routine 1-year surveillance cysto, and you haven't seen them for the past year. You have thousands of other patients that you have to remember. How can you really remember what their scar looked like 1 year ago and what it compares to today? Well, perhaps you could simply just scroll into your office EMR, look through this 3D image, see exactly where it was, and then have an immediate mental map of what you're looking for to compare when you do their cysto that day. But it also raises the question, is there a scenario in which you could have non-experts, whether that be nurses or technicians, that will do a cystoscopy under AI guidance? Perhaps the AI could tell them, you need to still view this area of the bladder. You need to rotate it this way. You need to do this in order to get the full image. And then for it to annotate in real time what areas it believes are tumors, stones, and scars, such that the urologist is able to review that at the comfort of their office or their computer and make an informed decision on whether or not they need to be resected and what needs to be done in terms of their treatment without ever having done the cysto themselves. Not saying that's what's going to happen, but it's an interesting thought. But beyond that, AI has been shown to be potentially very useful on a macroscopic level, but there's also been some work done on the microscopic level. And I'd like to thank Dr. Manis and Takeshi for providing use of these slides, which is still some unpublished information. So I'll touch on this very briefly. But if any of you have been to Dr. Manis's clinic and you've seen the TP biopsies, you've likely seen him use this special microscope called a stimulated Raman microscope. And the exact mechanism by which it works is a bit complex, but in essence, 2 laser beams are shot into a material, in this case, tissue, and it excites its vibration, causing it to generate a beam called a Stokes wave, which is then absorbed and sensed by the microscope. And this can then be used to create kind of a pseudo-coloring appearance of the tissue at high resolution, which can be similar in appearance to that of H&E staining without ever having to stain the image itself. And they've already shown that you can create very high resolution pathologic images of unstained prostate tissue in the span of just minutes, and then subsequently analyze it with artificial intelligence to determine what parts of the biopsy are actually malignant or benign, and if there is any concern for cancer. This is an example figure here, but towards the left, you can see examples of the SRH images and then the AI segmentation of different parts of the image as to what it believes is suspicious versus not. But this is prostate cancer. I mean, we're talking about bladder cancer here. But they're also exploring the use of this technology in the context of bladder biopsies. So this is an example of SRH images taken of bladder biopsies now too. Raising the question, once they start integrating the use of AI to analyze these images, could you potentially have a very fast point of care assessment, essentially a pathologic diagnosis at the time of TURBT about whether something is muscle invasive or invasive into lamina propria? Could you tell with definitive confidence that you have muscle in that specimen? Could you reduce the rate of repeat TURBTs? Kind of similar questions as to OCT, but now you actually have proper images with histology or histology equivalent rather than just the image that you take from a probe. I'm sure those questions will be further answered once Dr. Manis and Takeshi and the group publishes, but I'll leave it at that for now in terms of just a little filler or a preview of their work. So overall, AI, we're on the verge of a paradigm shift. It evolves incredibly quickly. There's already some evidence to suggest that we can more accurately and rapidly identify lesions compared to expert urologists to some degree, and future directions that are still pending. What might it look like to integrate AI to help guide your transurethral resection? Could it tell you areas of the image that you still need to resect? Could it tell you that your margin needs to be taken further? And once we do start seeing it used in vivo in actual studies, could we then expect that there's going to be prospective randomized trials to evaluate the differences in outcomes with the use of AI-guided cysto or TURBT? I think it's very likely, but it's a matter of time. And then likewise, could we be on the verge of changing the way that pathology is done in the means of using SRH and AI interpretation of those images to rapidly get an idea of what the stage or grade of a bladder lesion is in real time to inform your decision-making at the time of TURBT? But AI still has its challenges. So to map a bladder, you need to be able to see all of it. And rigid cystoscopy cannot necessarily visualize all parts of your bladder very easily. However, you could argue that that's the same when you're doing a TURBT anyways. Sometimes it can be quite challenging to reach those parts of the bladder. If you have poor visualization, lots of hematuria or debris, AI can't compensate for that, and it would likely scatter the image and make it very difficult for any evaluation under AI guidance. And then this is more of a discussion around where the future of follow-up might look like. But if we do end up wanting to integrate 3D bladder maps as a means of follow-up, we're going to need a complete overhaul of our systems, because the small computers at the hospital, at your office, they're probably not equipped to take on this vast amount of imaging and data. And to upload to the cloud is going to require an overhaul in terms of our EMR systems. So in conclusion, what have we discussed today? Well, we've shown that blue light cysto can improve your identification of tumors, can reliably reduce your risk of recurrence, and may even reduce your risk of progression. And even if that risk of recurrence is the thing that we are more anchoring on because the evidence around progression is not as strong, that alone has impacts on treatment quality, on treatment burden, on your quality of life for patients, and economic impacts as well. Kind of similarly, NBI likely aids identifying tumors, but the overall impacts on outcomes are, I think, not as strong as that for blue light cysto, but it doesn't confer any additional costs. There are no documented risks associated with it. So there are many contexts in which perhaps you might as well try using NBI, because it could help you detect more lesions and it may improve your outcomes. And both of these have been guideline recommended. But beyond that, some of the more emergent technologies, OCT, it potentially promises a future in which you're able to do a point of care assessment of bladder lesions, demonstrating not only evidence of malignancy, but also potentially depth or grade. But obviously, we need more further prospective comparative trials before we're really able to assess the adoption of this as a reliable diagnostic modality. And then finally, artificial intelligence rapidly evolving, rapidly improving, might already be more proficient in terms of identifying kind of borderline cases of malignant lesions than we are. But we still await to see how they're going to be integrated as an adjunctive tool in a clinical setting. And once that is done, we're going to need prospective randomized comparative trials and whatnot before we're going to see more widespread adoption of this technology in your day-to-day workflow. But I'd like to thank Dr. Black for guidance around this topic, as well as Dr. Manis and Takeshi for allowing me to use their slides and for allowing me to introduce a little bit of their work that still hasn't been published. So I'm happy to take any questions now.